We know that rituximab with chemotherapy and rituximab maintenance in follicular lymphoma has had a major impact on the outcome in patients. However, intravenous rituximab is associated with considerable healthcare resource utilization and also inconvenience for the patient, because they come in, they have to spend a number of hours sitting in the chair having their infusion. Rituximab has been reformulated by concentrating it down 12-fold and adding an enzyme called hyaluronidase, which is able to temporarily increase the space in the subcutaneous tissue. So you're able to give an injection of rituximab now in just 6 minutes, rather than sitting in the chair for very many hours. And we've done some preliminary work in phase 1b/2 trials looking at the dose, and we've established a dose of 1400 milligrams, which is a fixed dosing schedule rather than a sort of milligram per kilogram per body surface area dosing that we have previously used with the intravenous formulation. And so we have looked at the pharmacokinetics of the subcutaneous and the IV formulation, and we can see that there's non-inferiority of the pharmacokinetics in terms of trough levels and area under the curve. And we've established that already in the first part of the SABRINA study. So now we took a broader look at more patients, looking at more efficacy data and looking at more safety data. So the design of SABRINA is very simple. It's patients who have previously been untreated with follicular lymphoma, who have an indication for initiation of therapy. And they are being treated with a chemotherapy backbone, be it CHOP or CVP, which is at the discretion of the investigator, and they're randomized to receive their rituximab either by the intravenous route at the conventional 375 milligrams per meter squared, or by the subcutaneous route, which is a fixed dose of 1400 milligrams. And they have 6 to 8 cycles, and for those patients who have a response, they then continue with maintenance rituximab, either subcut or intravenously, given every 8 weeks for a period of 2 years. I think what's really important to note is that even if you're in the subcutaneous rituximab arm, everybody received their first cycle of rituximab intravenously as a kind of a safety measure. So the primary endpoint of the study was overall response rates and complete response rates, and we see no difference in the 400 people treated in both parts of the SABRINA study in terms of overall response rates and complete response rates. And that's investigator assessed and also those assessed by an independent review committee. There was no difference according to your body surface area. So if you were a bigger person and you received a fixed dose of 1400 milligrams, you weren't underexposed as a result. So we also looked at time to event analysis, and we looked at progression-free survival with a median follow-up of now 34 months, and we see no difference in the progression-free survival between those patients who received subcutaneous rituximab and those patients who received intravenous rituximab, and no difference in the overall survival. So in the switch in formulation from the IV to the subcutaneous formulation, we see no difference in efficacy data. If you look at the safety profiles of IV and subcutaneous rituximab, they are near equivalent. There is perhaps more administration-related adverse events in the subcut arm, and that's largely erythema, swelling, discomfort that's transient at the site of the injection and is fully reversible. So really no difference in safety and efficacy, and clearly much more convenient for both the patient and will help free up healthcare resources by reducing the amount of time patients spend in chairs.